around the world. I'm Somnath Banerjee from Intas. On behalf of Intas, I welcome all of you to this online virtual learning platform. I'm sure this unique platform will help all of us to engage and enrich our knowledge. To keep the ball rolling for the MHG webinar, I would like to introduce one of our stalwarts, sir, mentors for many. So, is my slide moving? Hello?
No, it was not moving and it's gone now.
Okay. 1 second, sir. Yeah. So I would like to invite Professor Sri Dr. M.B. Agarwal, sir. Sir need not to have an introduction. Sir is always a mentor for many of our doctors around the world. Sir is a professor and head department of hematology at Bombay Hospital Institute of Medical Sciences, Mumbai. Sir is a consultant hematologist at Lilavati Hospital, Bridge Candy Hospital, Mumbai. Sir is the president of Mumbai Hematological Group, past president of ISHBT, an institution and stalwart in himself, inspiration for many teachers. India is fortunate to have him, who has enriched us with a collaborating with scholars in hematology across the globe and bringing them on the virtual platform every weekend. Sir has been awarded the prestigious The Inspiring Hematologist of India by the Economic Times. Sir has also been awarded the Guru Dronacharya Award by the Indian Leukemia Academy. So to keep the ball rolling, I'll request Dr. Sri Mohan Agarwal, sir, to introduce the speaker for today.
Thank you, Dr. Somnath Banerjee, for your kind words. So, good evening to everybody from India and good morning, good afternoon, belong to some other part of the world. Today, our guest speaker is a popular name, Dr. Vaishali Sanchorawala from Boston. She has already conducted a number of webinars for us and enriched us with the knowledge in the field of amyloidosis repeatedly. Today, she will be speaking on AL amyloidosis, contemporary breakthroughs, and current trends. This webinar is brought to you by Mumbai Hematology Group. It is supported by Intas and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from Intas for relentlessly supporting all our academic activities across the year. Mr. Yash Kalpesh and Team Perfect Square for managing the whole show flawlessly. Executive Committee of Mumbai Hematology Group for giving me this free hand to organize these academic activities. Our guest speaker, the most important person for the day, Dr. Vaishali Sanchorawala. All our discussants who are themselves eminent hematologists or medical oncologists themselves, and you participants for again sparing your Saturday evening, afternoon, morning. Tomorrow morning, 11:30 a.m. Indian Standard Time, we have Dr. Reena Nair from Tata Hospital, Kolkata, speaking to us on treating lymphoma in India in the era of polatuzumab and brentuximab vedotin. Our discussants, and we have got a galaxy of them over here, put up alphabetically. I'll very briefly introduce them to you. Most of them are from South India this time. We have Dr. Aditya Murli, Bangalore. Dr. Ashish Dikshit, Bangalore. Dr. Dinesh Sheikh, Mangaluru. Dr. Ganesh Jaisetwar, Hyderabad. Dr. Govind Babu, Bangalore. Dr. Jaswantini A.R., Hyderabad. Dr. Kripa Bajaj, Hyderabad. Dr. Krishna Prasad, Mangaluru. Dr. Mahesh Rajashekara from Bangalore. Dr. Malikarjun Kalashetty from Bangalore. Dr. Monica Chenareddy from Bangalore. Dr. Nishita Shetty from Bangalore. Dr. Pujita Baireddy from Hyderabad. Dr. Prashant Bhatt from Bangalore. Dr. Radhika KK from Hyderabad. Dr. Rajesh Krishna from Bangalore. Dr. Sadashivdu Gundeti from Hyderabad. Dr. Satish Kumar A from Bangalore. Dr. Sita Ram Andaran from Bangalore. Dr. Sharad Damodar from Bangalore. Dr. Shilpa Prabhu from Bangalore. Dr. Stalin Chaudhary Bala from Vishakhapatnam. Dr. S.V. S.S. Prasad from Hyderabad. Dr. Tejaswini Gudibande from Bangalore. And now, once again, to introduce Dr. Vaishali Sanchorawala, who requests no introduction to the audience today. This is just a formality to be completed. And again, very briefly, she's Director of Stem Cell Transplantation Program at Boston Medical Center. She's Director of Amyloidosis Center at Boston University School of Medicine. She's Skinner Professor of Amyloidosis Research in the Department of Medicine. She's Associate Editor of Amyloid, the Journal of Protein Folding Disorders. She's Secretary of the International Society of Amyloidosis for the year 20 to 22. Her research has led and defined the field of AL amyloidosis. She is recognized as one of the leading international experts and a key opinion leader in amyloidosis. With numerous publications and meeting presentations, she is one of the pioneers in the field of clinical research in AL amyloidosis. Her work in the treatment of AL amyloidosis has resulted in the evolution of standard of care for these patients. She is currently heading several clinical trials in the treatment of AL amyloidosis, two of which were conducted nationally through SWOG 0115 and SWOG 1702 and led to the publications in peer-reviewed journals. She is a part of the faculty at major international conferences in amyloidosis and has given many invited lectures across the nation and internationally. She is active in various non-profit organizations, regulatory authorities, and funding bodies as an expert on amyloidosis. She is a member of the Executive Steering Committee of Amyloidosis Research Consortium, which is developing pathways to education, patient voice, development of treatment, and across to novel therapies. She has helped to create and cultivate the next generation of physician scientists in the area of clinical research in amyloidosis. She regularly attends several patient information seminars and supports meeting groups in the US. Outside of the roles of direct research in clinical care, she has an interest in the working for charity organizations. Her educational background includes a product of St. G.S. Medical College, KEM Hospital, Mumbai, residency at University of Medicine and Dentistry of New Jersey, US, fellowship at Hematology Oncology Boston Medical Center, US, and fellowship in Stem Cell Transplant Boston Medical Center, US. Today, as I said, she'll be lecturing on AL amyloidosis, contemporary breakthroughs, and current trends. Thank you, and over to Dr. Sanchorawala.
Are you able to see my screen?
Yes.
Okay. So namaste to everyone who is joined this Saturday to attend this seminar. I am very, very grateful and deeply appreciative of Professor Agarwal's invitation and consistency in doing this for the past 4 to 5 years. And it is a great pleasure and honor to really talk to all my country mates about systemic amyloidosis, contemporary breakthroughs, and current trends. Dr. Agarwal, your introduction was very kind and obviously was not needed. So I'm going to be spending next hour or so on talking about systemic amyloidosis. I have done this talk in the past, and I have focused more on AL amyloidosis as I'm a hematologist, and this is for a hematology group. However, this time, I'm also going to talk about a different type of amyloidosis that is in the differential diagnosis of AL amyloidosis, which is ATTR amyloidosis, because it is increasing in recognition, as well as I've had several emails from India about this particular type of amyloidosis. Okay, let's see if I can. Okay, these are my disclosures. So this cartoon is of an average physician's approach to a patient with amyloidosis. A patient with macroglossia and raccoon eyes goes to his general practitioner, and the practitioner says, there are some things they don't teach you in medical school. I think you've got one of those things. And this remains extremely true, as the path to diagnosis of amyloidosis can be quite rocky as well as very complex, as AL amyloidosis is a rare disease with an incidence of 1.2 cases per 100,000 person years in the Olmsted County of Minnesota, as reported by Professor Kyle. Amyloidosis Research Consortium is a patient-led organization, and this organization conducted a social media survey in 2015 of about 500 patients with amyloidosis. And it was very surprising to note that the time from initial symptoms to diagnosis of amyloidosis was greater than 12 months in 40% of the patients. Moreover, the number of physician visits before establishment of diagnosis was greater than 2 for almost 60% of the patients. And even more surprisingly, only 4% of primary care physicians, who are supposed to be the gatekeepers of healthcare system, were able to diagnose amyloidosis. This survey in 2015 indicated significant delays and multiple physician visits before a diagnosis of amyloidosis was made. What is different in 2022? There is not much difference. Amyloidosis Research Consortium performed a community survey of greater than 1,200 patients and caregivers across the globe and reported their results here. The average number of physicians seen before accurate diagnosis of amyloidosis was made for AL amyloidosis was 3, and the most common barriers to diagnosis were misdiagnosis, trouble getting testing performed, and trouble finding a specialist. Similar results were also found in France, where 600 patients were surveyed, and the average time from symptom onset to diagnosis was 27 months, which is close to 2 years. So despite our efforts in increasing awareness and decreasing educational gaps by giving seminars, webinars, talks, and presentations at all the meetings, the patient journey has not significantly changed. Systemic amyloidosis is an umbrella term for diseases that share a common feature of extracellular deposition of pathologic, insoluble fibrillary proteins in various organs and tissues, leading to organ dysfunction, organ failure, and death. The pathognomonic feature of systemic amyloidosis is a misfolding of extracellular protein, which leads to formation of bundles of beta sheet pleated fibrillar structures, which are deposited in various organs and tissues. Now, this is also when good proteins go bad. The extracellular precursor protein is soluble and is present in all of us. And as we age, or as a mutation occurs, this protein becomes insoluble and starts to form bundles of beta sheet pleated structures. The hallmark feature of diagnosis of amyloidosis is Congo red stain, which, when examined under polarized light microscopy, shows apple green birefringence. International Society of Amyloidosis has a nomenclature committee that updates the classification every 2 years. Amyloidosis can be classified as systemic forms or localized forms. Systemic amyloidosis is defined as amyloid fibril deposition occurring away from the site of precursor protein production, the most common one being AL amyloidosis, where amyloid fibril deposition occurs in the organs away from the site of precursor protein production, which is the immunoglobulin light chains occurring in the plasma cells in the bone marrow. The second most common form of systemic amyloidosis is familial amyloidosis, or hereditary type of amyloidosis, where amyloid fibril deposition occurs in the kidneys, heart, nervous system, away from the site of precursor protein production, which is usually the liver. In contrast, localized amyloidosis is defined as deposition of amyloid fibrils at the site of production of precursor protein. The most common one being the Alzheimer's disease, where amyloid plaques are formed in the brain at the site of A-beta precursor protein. The molecular events that lead to amyloid fibrillogenesis are depicted in this cartoon. There are approximately 40 precursor proteins that have been identified that can lead to amyloid fibrillogenesis. And these proteins, the common ones are depicted over here, which are either the immunoglobulin light chains or transthyretin protein. Once these proteins misfold, they interact with proteins surrounding them, and they form amyloid fibrils, which have the same X-ray diffraction pattern. The amyloid, they are 8 to 10 nanometer in diameter. They're non-parallel, and they all stain with Congo red staining, depicting apple green birefringence when examined under polarized light microscopy. This cartoon also demonstrates the pathophysiology of amyloid formation. Here, the risk factors or precipitating factors are either increased concentration of the soluble precursor protein, intrinsic instability of the soluble precursor protein, mutations in the soluble precursor protein, or because of increased proteolytic cleavage, there would be formation of misfolded protein, and also related to increased supply and decreased intracellular or extracellular protein quality control systems, either related to aging or related to other mechanisms, leading to formation of soluble oligomers or protofilaments, which interact with serum amyloid P protein and glycosaminoglycans to form amyloid fibril deposition. Few words on hereditary ATTR variant amyloidosis. This is an autosomal dominant disease with variable penetrance. The mutant transthyretin protein is inherited. However, the amyloid fibrillogenesis does not happen till midlife. Transthyretin is a normal protein that we all have, which is a transport protein for thyroxine and retinol binding protein. There are 100 different point mutations of transthyretin protein. However, clinically important ones are valine to methionine replacement at 30 amino acid, T60A, or V122I. V30M mutation is commonly found in Portuguese ancestry, and we've had several cases of V30M mutation in patients of Indian origin because of colonization of Portuguese people in the Goa region. T60A mutation occurs in Northern Ireland patient population, so it is very common in Boston because Irish people are all here in Massachusetts. And V122I is common in African Americans or Black patients. The treatment for hereditary ATTR amyloidosis used to be liver transplantation, and now we have a very, very expanded therapeutic landscape for this particular disease that I will be talking about in next few slides. So it is important for us to know about ATTR amyloidosis because the clinical presentations can overlap with AL amyloidosis. And the TTR amyloidosis can be either related to variant transthyretin protein because of point mutation in the transthyretin protein, or can be related to wild-type transthyretin that can form fibrils in senile systemic amyloidosis, or also known as ATTR wild-type amyloidosis. As mentioned earlier, ATTR variant amyloidosis is related to transthyretin point mutation. there are other proteins, which are large serum proteins that can also misfold related to mutations, either in fibrinogen, lysozyme, ApoA1, ApoA2, or gelsolin. The clinical phenotype, however, is quite different than AL or ATTR amyloidosis in this particular type of hereditary amyloidosis. And as mentioned earlier, ATTR wild-type amyloidosis is usually a disease of aging. It is usually the clinical phenotype is cardiomyopathy, and the patients are greater than 70 years of age, and men are more commonly affected than women. Now, this slide demonstrates the pathogenesis of ATTR amyloidosis in side-by-side with AL amyloidosis. As shown in the left panel, AL amyloidosis is a disease of plasma cells or plasma cell dyscrasia, whereas ATTR amyloidosis the precursor protein arises from the liver. It undergoes misfolding. There are dimers and dissociated monomers that leads to formation of misfolded aggregates or oligomers, which leads to formation of amyloid fibrils. So the precursor protein production occurs at different organ level. These are the clinical presentations of ATTR amyloidosis, and there is an overlap of clinical presentations with AL amyloidosis. And on most of the ATTR amyloidosis, it is cardiomyopathy, autonomic neuropathy, and peripheral neuropathy. And this, as you can imagine, are also manifestations of AL amyloidosis. And this cartoon again demonstrates the complexities of AL and ATTR amyloidosis due to overlap of clinical syndromes, as seen in orange, that cardiomyopathy, peripheral neuropathy, autonomic neuropathy can occur in both diseases, and it may become quite challenging diagnostically to identify them just based on clinical aspects. And this is, again, a zebra of many stripes is ATTR amyloidosis. Depending on the mutation in the transthyretin protein, the clinical phenotype is different. As mentioned earlier, T60A, which is the Irish variant, leads to cardiomyopathy. V122I, which occurs in Black patients, leads to cardiomyopathy, whereas V30M, which is present in Portuguese individuals, leads to autonomic and peripheral neuropathy. This was actually published in Blood, and it is very, very true that the therapeutic landscape of ATTR amyloidosis has expanded since 2018 with the first approval of transthyretin stabilizer approved by the FDA in 2018. We have transthyretin stabilizers like tafamidis, and now also acoramidis, which is going to be approved soon. We have transthyretin small interfering RNA inhibition with patisiran and with vutrisiran. We have antisense oligonucleotides, which are inotersen and eplontersen, and these are all getting FDA approval. There's also CRISPR-Cas9 TTR gene editing that a phase 3 clinical trial is ongoing for ATTR amyloidosis. So, again, that, it is important to differentiate these two diseases because the treatments are very, very different. Now, moving on to AL amyloidosis, the incidence of AL amyloidosis, which is a plasma cell dyscrasia and which is our hematological condition, has remained stable over a 9-year period, ranging from 9.7 to 14 cases per million person years. And this is based on the US claims database published in 2018. However, the prevalence of AL amyloidosis has increased significantly over a 9-year period from 15.5 to 40.5 cases per million because of significant increase in therapeutic landscape and available therapies. Again, briefly, the pathogenesis of AL amyloidosis begins from a dangerous small B-cell clone in the bone marrow, producing kinetically or thermodynamically unstable light chains, which interact with cellular and extracellular matrix and extracellular chaperones to form soluble oligomers. These soluble oligomers then interact with serum amyloid P protein and glycosaminoglycans to form amyloid fibrils. Now, the mechanisms for organ dysfunction are twofold. It is logical to think that the organ dysfunction occurs because of loss of architecture and mass action because of deposition of amyloid fibrils in the organs. However, more recently, we've also noted that there is direct cytotoxicity of soluble precursor proteins or soluble oligomers on the organs, leading to organ dysfunction. And this slide demonstrates two animal models of zebrafish and C. elegans, where amyloidogenic light chains were injected to these animals, leading to impairment of relaxation and contractility of the cardiac muscles. We at Boston University have also, Camille Edwards is one of our junior faculty members, who is looking at the molecular mechanisms that drive the amyloidogenic light chain induced cardiac toxicity in the induced pluripotent stem cell derived cardiac myocytes and modeling. And what she has found at that there is upregulation of transcripts that are associated with cardiac hypertrophy and cardiac remodeling, whereas downregulation of transcripts associated with adaptive immune responses. And this has led us to believe that amyloidogenic light chains can lead to negative cardiac chronotropic effects without even formation of amyloid fibrils. These are the clinical presentations of AL amyloidosis. The most common organ that is affected by AL amyloidosis is the heart and the kidneys. Heart is affected in 70% of patients with AL amyloidosis, and kidneys are affected in 65 to 70% of patients with AL amyloidosis. There are certain pathognomonic features of AL amyloidosis, which is spontaneous periorbital ecchymosis, because of capillary fragility, macroglossia as demonstrated by indentation of teeth mark on the lateral borders of the tongue, submandibular gland enlargement, and acquired factor 10 deficiency leading to coagulopathy. These are hallmark features of AL amyloidosis, and these rarely occur in patients with other types of systemic amyloidosis like ATTR amyloidosis. Diagnosis of AL amyloidosis requires two steps. The first step is the biopsy of the target or surrogate site and subjecting it to Congo red staining. We usually perform an abdominal fat pad aspiration, which is a bedside procedure under local anesthesia, which is positive in 75 to 80% of patients with systemic AL amyloidosis. Bone marrow biopsy can demonstrate presence of amyloid deposition by Congo red staining in 70% of patients, and minor salivary glands can be positive in 80% of patients. Once a tissue diagnosis of amyloidosis is obtained by Congo red staining, it is absolutely crucial and fundamental to unequivocally identify the amyloid precursor protein in order to offer appropriate treatment, to assess prognosis, and to offer genetic counseling when appropriate. It would be absolutely non-ethical to treat a patient with ATTR amyloidosis with chemotherapy, Cyborde plus daratumumab. How do we perform typing of amyloid deposits to accurately identify the amyloid precursor protein? So immunohistochemistry by commercial antibodies is generally unreliable in 2/3 of patients with systemic AL amyloidosis. Ultrastructural electron microscopy immunohistochemistry with gold label antibodies of commercial antibodies has specificity of 99%, however, is not available commercially and is available only at Boston University and University of Pavia in Italy. The gold standard for accurate typing is mass spectrometry-based proteomics, and it is very, very sensitive and specific because it does not rely on commercial antibodies, and it is easily available at the Mayo Clinic laboratories. So the bone marrow plasma cell clone in AL amyloidosis is usually quite small, with a median number of plasma cells of 10% and less than 5% in 20% of cases. The diagnostic sensitivity of the tests that are listed over here are also listed. We will focus on the last row in this table, the serum and urine immunofixation electrophoresis and serum-free light chain ratio would have a diagnostic sensitivity of 98% in all the studies performed across the globe for AL amyloidosis. However, 2% of patients with systemic AL amyloidosis would not have a demonstrable monoclonal protein by this currently available test. And novel mass fix, which is a mass spectrometry-based immunofixation technique, may increase the diagnostic sensitivity. And this slide demonstrates the levels of detection of monoclonal protein by different techniques. And as you can see, serum and urine protein electrophoresis should not be used as screening tests for AL amyloidosis because the monoclonal protein concentration is quite low and it is often negative in patients with AL amyloidosis. The mass spectrometry-based test, MassFix and MyRAM, are not commercially available yet, but hopefully they will be available soon. The plasma cell clone in AL amyloidosis is different from its cousin, multiple myeloma. It's not just the clone size, which is smaller in AL amyloidosis, but there are also different different cytogenetic aberrations that are seen in patients with AL amyloidosis. And as shown here, cyclin D1 is a more prominent driver in AL amyloidosis than in multiple myeloma. And translocation 1114 is present in almost half of the patients with AL amyloidosis compared to a quarter of the patients with multiple myeloma. Once the diagnosis of AL amyloidosis is obtained, it is fundamental to stage and risk stratify the patients. Mayo Clinic investigators in 2004 developed the biomarker-based staging system for risk stratification based on N-terminal pro-brain natriuretic peptide and troponin levels, and they classified patients into three stages, which correlated with the overall survival. The European investigators from Dr. Wecklicker's group at National Amyloidosis Center modified this staging system and showed that NT-proBNP of greater than 8,500 picograms per ml, called stage 3B disease, had a median survival of less than 6 months. Dr. Kumar's group from Mayo Clinic also updated this staging system by incorporating markers of plasma cell dyscrasia with difference between involved and uninvolved light chains, along with cardiac biomarkers, discriminating patients into 4 stages, predicting for overall survival. Again, in this staging system, stage 4 patients had a median survival of about 6 months. So median survival of 5 to 6 months for patients with advanced cardiac AL amyloidosis with NT-proBNP of 8,500 picograms per ml remains a medically unmet need in this disease. We at Boston University developed a staging system incorporating brain natriuretic peptide and not NT-proBNP and troponin I, and were able to discriminate patients into 4 different stages, again with stage 3B corresponding to a median overall survival of approximately a year. We at Boston University again looked at our patients from 2010 to 2020 with 142 patients who had NT-proBNP of greater than 8,500 picograms per ml and showed that the median overall survival in the era of bortezomib-based frontline therapy improved to 9 months. And we also found that the early treatment responses with hematologic response occurring at 1 month and cardiac response occurring at 3 months predicted for better overall survival in the range of 4 years for this very sick patient population. Similarly, biomarker-based staging system has been also developed for renal involvement that can predict for a risk of dialysis at 2 years and annually. And these biomarkers are 24-hour urine total protein excretion and estimated glomerular filtration rate, again for stage 1 patients, 2-year risk of dialysis of 0 to 3% compared to 60 to 75% for stage 3 patients. Cardiac involvement remains the driver of overall survival in patients with AL amyloidosis. So diagnosing cardiac involvement earlier in the course of the disease would be extremely helpful. And there have been significant advances in the imaging techniques for cardiac amyloidosis. Transthoracic echocardiography remains the gold standard and cornerstone for diagnosis of cardiac involvement. However, recently, global longitudinal strain analysis also has been demonstrated to diagnose cardiac involvement earlier in the course of the disease, and it also improves significantly post-treatment. Cardiac MRI with T1 mapping and late gadolinium enhancement with expansion of the extracellular volume, as well as a PET CT scan with 18F-fluoro beta pair can identify cardiac involvement earlier in the course of the disease. A few words on bone scintigraphy. Bone scintigraphy with either technetium pyrophosphate or a DPD radionuclide materials are the gold standard for diagnosis of ATTR cardiac amyloidosis. Most of the time, AL amyloidosis has negative uptake for PYP or DPD scans. PYP is done in the United States and DPD is done in Europe. But this is the diagnostic criteria or diagnostic test, which is a non-invasive biopsy, not needed test for ATTR amyloidosis. Furthermore, new radionuclide materials are available, one called I-124 evuzabmitide, which is a PET imaging, which is a PET nucleotide, which can be used for PET CT in diagnosis of all types of amyloid cardiomyopathy. This is not yet FDA approved for routine uses. Now focusing on treatment. So the treatment is targeting the production of soluble precursor protein in AL amyloidosis, which is the plasma cell dyscrasia. Before we begin on the treatment, there are certain key elements that are crucial for improving outcome of patients with AL amyloidosis. And these elements are early diagnosis and accurate typing and accurate precursor protein identification. There is a fine balance of chosen treatment regimen and patient's ability to bear toxicity. It is also important to note that hematologic complete response is not always needed to achieve an organ response. Moreover, the organ response can take 3 to 12 months after achievement of hematologic response to occur. And as shown here in this, the median time to organ response was 10 months in this study from the Mayo Clinic, ranging from 8.7 to 13 months. The goals of therapy are to achieve a hematologic response as demonstrated by the plasma cell dyscrasia biomarkers, with the hope of improving organ dysfunction as again demonstrated by organ biomarkers, and then to prolong survival. This is a 40-year a natural history longitudinal study from Boston University Amyloidosis Center of 2,300 patients, showing a dramatic improvement in 5-year overall survival in the mid-early 1980s of 15% 5-year overall survival to 48% in the more contemporary era. And this has been attributable to the expanding therapeutic landscape of AL amyloidosis, most of which are borrowed from the treatment of multiple myeloma. A word on these 2 randomized pivotal historical clinical trials, which were the conventional treatment prior to 1990s, where oral melphalan and prednisone improved median overall survival of patients with AL amyloidosis to 12 to 18 months. However, long-term survivals and hematologic complete responses, as well as organ responses, were not obtained by this treatment regimen. We at Boston University developed high-dose melphalan and autologous stem cell transplantation for the treatment of AL amyloidosis, and this aggressive treatment approach was prompted by promising results of similar treatment regimens in multiple myeloma in early 1990s. Objectives of the initial clinical trials of stem cell transplant in AL amyloidosis were to determine tolerability of this aggressive treatment approach in patients with multi-system organ involvement, to determine efficacy of this treatment in inducing complete hematologic response. And we reasoned at that time that since the plasma cell burden was low in AL amyloidosis, we might achieve higher complete hematologic responses. And finally, to determine whether complete hematologic response leads to improvement in amyloid-related disease and improved survival. This is our 25-year experience at Boston University of 648 consecutive patients treated with stem cell transplant for AL amyloidosis, with a median overall survival of 7.6 years and a 10-year survival of 67% in the more contemporary era. The median duration of hematologic complete response is 12.3 years. And the International Society of Amyloidosis and European Hematology Association published the guidelines for high-dose chemotherapy and stem cell transplant for systemic AL amyloidosis in the Amyloid Journal a few years ago. Only 20% of patients with systemic AL amyloidosis are eligible to receive stem cell transplantation. Andromeda clinical trial, published in the New England Journal of Medicine, is now FDA approved for treatment of new diagnosis of AL amyloidosis. And 80% of patients do get treated with this treatment regimen. And as shown here, that patients who were randomized to receive daratumumab plus cyclophosphamide, bortezomib, dexamethasone, Cybor-D, or VCD, had a higher hematologic complete response rate of 50 to 60% compared to 20% for Cybor-D alone. Similarly, organ response rates also were in the range of 50 to 55% for cardiac and renal responses, favoring Dara-Cybor-D compared to Cybor-D alone. And this has led to FDA approval of this regimen for patients with AL amyloidosis. ISA and EHA working group published the guidelines for non-transplant chemotherapy for treatment of systemic AL amyloidosis, and Dr. Wecklicker was the first author on this paper. It is important to note that the organ response takes time, and this table shows you time from treatment initiation to initial organ response in the first column, and time from treatment initiation to best organ response in the last column. And as you can see, the best organ response can take 2 to 3 years after achievement of hematologic response. Dr. Mukhtar and his international collaboration has led to graded cardiac response criteria published in JCO a few years ago, showing that if there is normalization of cardiac biomarkers or cardiac complete response, the overall survival is extremely good, as shown by these Kaplan-Meier survival curves. Daratumumab, monoclonal anti-CD38 antibody, has been a game changer for treatment of AL amyloidosis. This slide is an aggregate of all the studies published with 625 patients treated with daratumumab, and they were previously untreated versus relapse refractory settings, and again, leading to very high hematologic response rates of 80 to 90% and 40 to 50% hematologic complete response rates. So this has really been a game changer in the treatment of AL amyloidosis. Few words on venetoclax, which is a small molecule targeting BCL2. And as stated earlier, translocation 1114 occurs in 50% of patients with AL amyloidosis. This was a retrospective chart review study of 9 different centers showing that patients who were treated with venetoclax who harbored translocation 1114 had a high hematologic CR, VGPR of almost 80%. However, we must look beyond the plasma cells, as organ dysfunction and amyloid deposition in the organs really leads to reduction in quality of life, as well as reduction in overall survival and organ dysfunction and failure. Therefore, it is critical to combine different targets to treat this complex disease by suppressing precursor protein production, by stabilization of misfolded precursor protein, and offering anti-amyloid fibril depleters to clear the amyloid fibril deposition from the organs. And we are at Boston University in the process of developing a light chain stabilizer as a therapy for AL amyloidosis. There are several clinical trials that are ongoing or are awaiting analysis. One of them is a birtamimab clinical trial that is currently still accruing in the United States called AFFIRM-AL, which is an amyloid depleter or amyloid busting agent, and birtamimab in a phase 3 VITAL study, which was discontinued for futility analysis. On a post-hoc analysis did show that a 9-month all-cause mortality as well as certain secondary functional endpoints were better for those who were treated with birtamimab plus standard of care compared to placebo for standard of care. And this trial, confirmatory trial, is on currently accruing. CALM 101, which is a again another amyloid busting agent or amyloid depleter, has completed a phase 3 clinical trials and is awaiting analysis of those trials. Again, in phase 1AB open label study, there were patients who had significant cardiac responses either by traditional criteria as well as by biomarker-based criteria, including the global longitudinal strain analysis. Supportive care is a fundamental part of an integrated treatment approach, and it requires coordinated expertise of several subspecialists familiar with the disease. The goals of supportive care are to improve organ function, maintain quality of life, and prolong survival. This is the multidisciplinary care model that we use at Boston University, where patients are seen by all the subspecialists under one roof. And, you know, it is not yet over, that this is not enough. There are certain unmet needs, and future direction should focus on improving early diagnosis, to define standard of care for advanced cardiac stage patients, to validate a definition of hematologic progression, to evaluate new techniques like mass spectrometry and MRD assessment to assess response, and to focus on alternative treatment targets as well. And with that, I would like to acknowledge all the members of the clinical as well as scientific teams at Boston University Amyloidosis Center. I'm sorry to run over a little bit.
Thank you. Thank you, Dr. Vaishali. That was a wonderful talk, a real update. You exposed us to the whole subject of systemic amyloidosis so beautifully. We have a number of colleagues over here who may like to ask you questions. And I also request all the audience to put their question in the chat box. We begin with Dr. Ashish Dixit from Bangalore. Ashish.
Very nice talk indeed. Very few information that I've got in terms of new development also. So just a practical point I wanted to ask. We come across it once in a while. For a patient who is having a systemic amyloidosis proven on a AL amyloidosis on the bone marrow, and you are finding a technetium scan which is showing ATTR, how do you approach it? Do you go for a pericardial biopsy, try and find out, or you take it as coexistence? Your thoughts?
So, so these are real life questions, real world questions, because patients are living till longer, and we have that it happens here as well. I think that the diagnostic algorithm for diagnosis of ATTR amyloidosis based on bone scintigraphy, if there is presence of plasma cell dyscrasia, asked for endomyocardial biopsy. And I think that is what we would do. We have been doing because of this, we've been doing, I just actually pulled up our cases, we've been doing anywhere from 10 to 15 endomyocardial biopsies a year. And majority of the times it is something like this, that they have evidence of monoclonal gammopathy. And, it is very common to have monoclonal gammopathy because as you get older, you are going to have 3 to 5% of patients are individuals, not patients. Individuals are going to have monoclonal gammopathy. And whether that is the culprit causing cardiomyopathy, it is not known. And, it is, I think, in a real world and ideal setting, I would obtain an endomyocardial biopsy. Because we've seen that they both can coexist. We have seen that, that this is just a monoclonal gammopathy of unknown significance, and it is only ATTR amyloidosis. And then the treatment would be something to stabilize the transthyretin protein. If it is AL in the heart, which usually should not really have an uptake on the PYP scan or bone scintigraphy, then, the treatment should be obviously chemotherapy.
Thank you.
Mm-hmm.
Thank you, Ashish. So in the era of DARA Cyborg D, what's the place of autologous transplant now?
Very good question. And this is, a big, huge debate that is happening in this world. And, again, my dear friend, Ashu Wecklecker, was very much against stem cell transplant. The whole National Amyloidosis Center was very much against stem cell transplant in the 1990s. Because, the morbidity and mortality associated with stem cell transplant was very, very high. And patient selection was because we had no other treatments. We used to do stem cell transplant. So, and now they are all favoring stem cell transplant. Because, I will tell you that only 50 to 60% of patients with DARA Cyborg D are going to achieve a hematologic complete response. The organ responses at 18 months are, again, also 55 to 60%. So, there are 40% of patients who are not going to achieve a very, very good hematologic response. And I think those patients should be offered stem cell transplant. I think that what is happening in the US is that because DARA Cyborg D is so well tolerated and it is so easy to give in the community, that patients are getting started on DARA Cyborg D before they get to a referral center, and patients are already in a hematologic response. So then, we are not really offering them stem cell transplant. But I think that the role for stem cell transplant in newly diagnosed patients with AL amyloidosis is definitely going down.
So if you have a transplant fit patient, will you offer that as the first line of treatment in the era of DARA Cyborg D?
So, I didn't really talk about all that, but yes, we would. If it is renal stage 1 with minimal proteinuria, fit patient, no heart involvement, good functional status, young person, probably yes. Because, it's a time-tested strategy. We've been doing it since 1990s. If you achieve a hematologic complete response, the duration of median duration of response is 12 years. of post-stem cell transplant. And, we don't really know, we have no data on overall survival or, organ responses or anything else with dara-CyBorD yet. So I think that we would. The patients may not want it, but, we would.
And a person who has responded well to 6 months of dara-CyBorD, will you consolidate with an autologous upfront?
Right. Personally, I don't do this. That is how our EHA ISA guidelines are as well, that you want the organs to recover as much as they need to. So, and they may not relapse for next 3, 4, 5 years after dara-CyBorD. We don't know. But if they do relapse at 5 years down the road, you are going to be following the patient. So you would know before the organs start to get affected that you need to do some second line of treatment and maybe stem cell transplant at that point. But we are not really doing a lot of consolidation. There is a SWAP clinical trial that is just going to start accruing, which is a trial of newly diagnosed patients treated with 3 cycles of dara-CyBorD, then randomized to continuation of dara-CyBorD like Andromeda or stem cell transplant. The accrual goal is 360 patients. I have a feeling that trial is not going to accrue. I'm obviously one of the investigators on the trial, but it is my sense that that trial is going to be very hard in the US to accrue.
Before we go to Mallikarjun, one more question. Do you believe in the maintenance therapy in AL amyloidosis? No maintenance therapy.
Right. So, I don't. So maintenance therapy has no role in AL amyloidosis because the plasma cell burden is very low. Most of the time when you achieve a hematologic complete response, it's very, very durable. Patients who have myeloma associated AL amyloidosis. So, if it is greater than 10%, greater than 20% plasma cells, then maybe, those patients should have maintenance therapy.
Thank you. Yes, Mallikarjun, sorry, kept you waiting. Yeah.
No problem, sir. Good evening, sir. Good evening. Thank you for a wonderful presentation. Just a couple of questions. Number one, apart from clone-directed therapy in AL amyloidosis, would you do something else? The investigational therapy that you just mentioned, are they being done in the clinical world? Number two, most common thing that we see.
Let's take up one by one.
Yes.
You have all the times. Yeah.
Yes.
I know, because I can never remember otherwise, No. So the first question is about
Ancillary complementary therapy.
Clinical trials. So clinical trials are ongoing. So there are several clinical trials are ongoing, which are either directed towards the fibrils or the amyloid deposits. And those trials, as I said, KELAM 101 is close to accrual and they are waiting for analysis events to happen. And then the other one is AFFIRM-AL, which is currently ongoing, which is birtamimab. There is also a clinical trial that is ongoing called Aquarius clinical trial, which is deferred CyBorD. Can we really achieve a hematologic response just with single agent DARA? So we do daratumumab for 3 months and then we add CyBorD. So that is the clinical trial that is ongoing. That trial also has a second cohort, which is enrolling patients of racial and ethnic minorities, because in the Andromeda clinical trial there were only very few patients, and also they noted that the DARA exposure in Black Americans was significantly higher than Caucasians. So so that trial is ongoing currently. But yes, we try to enroll as many patients on clinical trials as possible to advance science.
So thank you. So are all of your patients by definition getting quadruple therapy frontline, or frail patients would only do DARA, BOTI-DEX, or CyBorD? All of us have always used CyBorD all along. Now, in certain frail patients, if we want to do DARA, I always worry, should we do just DARA, BOTI-DEX, and then add cyclophosphamide if they tolerate well?
Right. So that's a great question, So there is an EMN, European Myeloma Network trial for patients with stage 3B disease. So again, patients who are extremely frail with advanced cardiac amyloidosis, they are treated with daratumumab alone as monotherapy. And in that, they've enrolled 40 patients and the median overall survival was better than historical overall survival of less than 6 months to 10 months. 1/3 of the patients did require addition of CyBorD. So I think the culprit in frail patients is the bortezomib. I would not really use bortezomib because it causes hypotension that patients can't tolerate. It causes a lot of GI issues that patient can't handle, and it can also cause untoward cardiac effects. So I think single agent DARA to start with. I think the problem in India is that it is still available as intravenous infusion. So
We now have
We have the subcutaneous Fast Pro now. Yeah.
We have it for last 2 months.
Yeah.
Oh,
Yeah.
okay, okay. So then, that's much better. I'm sure it is expensive as hell that not everybody can afford it.
It is cheaper than IV.
Yeah. They have
Is
better
that
patient
right?
assistance. Yeah. Yeah.
Oh
It is
my
still
goodness.
costly, but yeah.
Yeah,
I
costly,
know.
but cheaper than IV.
Yeah. Yes.
I understand, So I think that is easy to tolerate. The subcutaneous formulation is very easy to tolerate. And I think I would recommend that we start out with subcutaneous formulation, weekly doses, 8 cycles and 8 weeks. And if there is no response, then gradually add bortezomib, cyclophosphamide, or
Sure.
sideboard.
Sure. Sir, last question, can I?
Oh,
Yes, sir. Yes. So the renal AL amyloidosis oftentimes is the commonest thing that we see, and then we treat them with induction after about 8 to 12. Some of them have just partial response. They have significant nephrotic proteinuria, and then there is a plateau of response, and it's not getting better. So what do we do in these patients? We know this protocol is not going to do anything better. They can't get to an autograft. Should we just stop and wait and watch, or do you switch them to second line then and there?
So, the treatment that we are doing is towards the plasma cell clone. So the nephrotic syndrome is going to take 2 years, 3 years for it to get better. Or the immediate 30% reduction in the proteinuria is going to occur only after 10 to 12 months. So I think that I would just focus on the hematologic response. If there is a hematologic response, which is defined as either absence of immunofixation, monoclonal protein on immunofixation, electrophoresis, and normalization of serum free light chain, then, I would continue treatment and, do supportive care, ACE inhibitors for reduction in proteinuria, obviously diuretics to control the swelling. But the nephrotic syndrome is going to take 2 to 3 years for it to improve. I think the goal is to achieve a very, very stringent hematologic response. And, in those patients, if they have a PR after, 3 cycles, 4 cycles, 3 or 4 months of Dara-Cyborg-D, and if it is just a PR, it is highly unlikely that they are going to deepen their hematologic response. And those patients might be considered for stem cell transplant as consolidation.
Thank you so much. Very kind of you. Thank you.
Thank you. So where do you fit in venetoclax?
I know that's also because see, venetoclax, the company did not really, they never ever did any prospective trials of venetoclax because I think they were so focused on getting it approved for the myeloma population that I think they got burnt, But having said that, I think that if patients have failed, if they have, they have to have translocation 11-14. And if they've failed Dara-Cyborg-D, meaning that they've not achieved a hematologic CR or VGPR, I think I would probably, and if they are not transplant candidate, I would do venetoclax. But I think the goal is to do fixed duration. I would not do it forever. I would probably do it for 6 months because they are going to achieve a very, very good responses within 1 or 2 cycles, actually.
And that would be monotherapy?
Dr. Agarwal, you have the most tough questions, So there is a clinical trial that is ongoing with venetoclax, ixazomib, dexamethasone. So, it is combined with proteasome inhibitor, but all oral therapy. And I have few patients on that trial, and within a month, they are in CR. So it is, but there's also a clinical trial, and this is all obviously for relapse refractory patients. And there is also a clinical trial that is led by Dr. Lynch from Columbia, and they are doing venetoclax dex alone, or not alone, without ixazomib for 6 months. That's for relapse setting as well.
Thank you. Dr. Sadashivlu.
Yeah, good evening, madam. The wonderful talk. I think we have learned many things today. Just just a doubt, madam. Are there any relative or absolute contraindication for stem cell therapy? Because after 4 to 6 cycles, they'll have some partial response. They'll have some cardiac comorbid conditions. So
So,
any
right. So, maybe, next time I will do a talk only on stem cell transplant because, role of stem cell transplant in AL amyloidosis, because, it is, I think each institution has a different inclusion criteria. So in that the guidelines that we published for EHA and ISA, we kind of reviewed those exclusion criteria. I think in clinical practice, if patients have systolic blood pressures of less than 90, I would not do stem cell transplant. If they have pleural effusions which are refractory to medical management, I would not do stem cell transplant. If they have significant cardiac involvement, NT-proBNP of greater than 5,000, I would not do it. Ejection fraction, obviously less than 50%, I would not do it. We also do several other functional assessments. We make them climb stairs up and down. If they are not able to climb 4 or 5 flights of stairs, then we don't really do stem cell transplant. So there is a lot of, if their EGFR is less than 30, then, I would probably not do it because, you're going to lose their kidneys, and during peri-transplant period. So I think those are like broadly the exclusion criteria.
Thank you very much, ma'am.
Thank you, Sadashiv. Dr. Amit?
Yes, ma'am. Thank you for that wonderful talk, ma'am. Again, I have the same question on the lines of transplant. Patient is very fit, young fit patient, stage 1 kidney disease, fit to undergo transplant, no cardiac comorbidity. Since we know that amyloidosis, the clone of plasma cells are very low. So is it okay that if you go with only melphalan of 100 milligram meter square and transplant the patient? Or we want 140, 100 is okay, sufficient?
I know. So we, again, I will come back to do a talk on role of stem cell transplant because I think stem cell transplant makes a lot of sense in India because patients who cannot afford it, I think transplant is quote unquote cheaper than doing daratumumab for 2 years. And, I kind of really know that. So, melphalan 200 versus 140 versus 100. Hematologic response rates are different. For melphalan 200, the hematologic response rate, complete response rate is about 50%, 35% for MEL 140. MEL 100 is down to 20%. So in the guidelines, I have recommended not to do MEL 140 or MEL 100. Just because, that the responses are lower, and is it really worth putting the patient through that treatment if it really doesn't really give you an advantage of hematologic responses. So 200 is what we would do. Again, obviously toxicities are significant as well. But our initial papers showed that the treatment-related mortality post-stem cell transplant was higher for 100 and 140 than 200. I think it is based on the patient that we chose. If we decided to give them 100 or we decided to give them 140 because they had significant heart involvement. So I think it was the substrate rather than the treatment.
Thank you, ma'am.
Thank you, Amit. Satish?
Thank you, sir. Thank you, ma'am, for that wonderful talk. I'm listening for the second time and enjoyed it again thoroughly. Again, a lot of new things to learn. My question or query, actually, Agarwal sir has already asked a patient with T1114. So I have a patient with newly diagnosed T1114 amyloidosis. So should I just start with Cybody or depending on his finances, Dara Cybody and just keep the venetoclax for when he relapses? Or do you think I should start with Ven and Dexa and see the response? Newly diagnosed.
I know. So there is no trials of venetoclax in upfront setting, even in myeloma. So I would say that I would use venetoclax for relapsed or second line setting. I think Dara is still very expensive, and I know that I get a lot of emails from a lot of people in India where, it is not affordable, and, I don't think I can afford it if I'm in India, it is, and then, people are getting it day 1, day 8, and then, 2 months, and then they stop, or they get it for a month and they stop because they can't really afford it, So I would say that, I would do standard of care treatment for first line, T1114, if they were to relapse, then do this. It has been shown in multiple small retrospective studies that bortezomib does not really do the trick for 1114s. But, there are no prospective trials. We still do bortezomib. We also had found that high-dose melphalan works better for T1114. But, having said that, I would still do Cyborg data, and then if they were to relapse, do venetoclax. Venetoclax is a very potent molecule, and I don't know what the pricing is of venetoclax in India, but it is very, very potent and it is well tolerated. So, you could definitely offer that earlier in the course of the disease rather than waiting for 5-6 years or third or fourth relapse.
Right. It is not available in India, but we can import it very easily now, ma'am. I mean, it's quite easily available. So do you use 100 mg or you go, like AML?
Right. So, what the clinical trials that I'm participating in are using 400. But I think I would do 400 for the first month. And as soon as you achieve a response, drop it down to 200 or 100.
Right.
And I think the critical issue with venetoclax would be infections. Because that is what the Bellini trial, the myeloma trials showed. So I think that, if you just do it for a fixed duration of 6 months, I think that, that would be I think the infection rates would be reduced. And in AL amyloidosis, if there is no reciprocal suppression of other immunoglobulins, the immune suppression is really not that bad as myeloma. So I think that we can get away with infectious complications.
Right. Thank you so
much. That is what my argument with AbbVie was, that how they needed to desperately do the trials in AL amyloidosis, but they never did.
Thank you. Can I ask one more question, sir?
Yeah.
Ma'am, again, to rule out cardiac amyloidosis, if we have a patient with, say, 10% plasma cells and we have demonstrated clonality, there is a light chain or some monoclonal gammopathy, and a CMR, cardiac MRI, has documented, and the pyrophosphate scan, if it is negative, are we happy enough to diagnose this as AL amyloidosis and go ahead, or do you recommend any other studies?
No, I think that, that you have to have a tissue diagnosis of amyloidosis. So, the question is whether, kidney biopsy has been done or fat or GI or something.
Patient, we are suspecting only cardiac amyloidosis. The cardiologist has referred. There is no proteinuria. So I think we can go ahead with abdominal if there is nothing in the bone marrow. And if the abdominal...
So then, the question is, does the patient really, because the cardiac MRI is negative for gadolinium positive?
Yes.
Right. So I would still get tissue diagnosis. I would not treat with cytotoxic chemotherapy, poisons without having tissue diagnosis. And these are also questions that they come from India quite a bit, that there is proteinuria, albuminuria, and then there is monoclonal protein. And, can we just not do kidney biopsy? And I always feel that, you don't want to really do this massive treatment without having tissue.
Yes, ma'am. So the problem is with the bone marrow biopsy and the abdominal fat part biopsy comes negative for congruent staining.
I know. So then, again, then I think the next one is, so, most of the time, what we say is 80% of the times, surrogate sites like bone marrow or fat would be positive in AL amyloidosis. In 20% of the times, it may not be. And then you have to biopsy the target organ. And in that condition, I think the heart biopsies in AL amyloidosis is, relatively speaking, not complicated because the heart is so thick that, they biopsy it and there is the chances of complications are very low. But, it has to be done in a center that really has the expertise. Even in the US, not everybody can do it. So that is what I would recommend. I think the other surrogate sites to document congruent positivity would be minor salivary glands, lip biopsy, so the ENT can do that very easily. It's an office procedure, or a rectal biopsy.
Right, ma'am. Sure, ma'am.
By sigmoidoscopy. Yeah.
Thank you. Thank you so much.
Thanks, Satish. Dr. Bilal has put a question about belantamab and its role in relapsed amyloidosis, AL amyloidosis.
Yeah, so belantamab, for those who do not know, is a antibody drug conjugate, and it is directed towards BCMA on the plasma cell, and it is taken off market here in the United States. It is available, I think, in Europe in some countries, and the largest data set comes from Dr. Wecklecker's group, showing very, very high response rates. I think the complications of belantamab is ocular toxicity with a lot of corneal issues and loss of vision, blurring of vision, and whatnot. So I think that if it can be given at an increased interval, we hope that the ocular toxicities would be lower, and the increased interval would be every 8 weeks to start out with, or every 6 weeks to start out with. But it requires a lot of, so I have used it in several patients when it was available, and it really works. It works very, very good, and very quickly we got responses. So I don't know if it is available in India or not. No, yeah.
Thank you. Dr. Nidhi has a question. AL amyloid, cardiac and renal involvement. Patient is on maintenance dialysis. There is a complete hematological response after DARA CyBorD. Will you do a renal transplant in this patient?
Absolutely. Absolutely. So there are lots and lots of papers. One of them is a multi-center trial, and I can send it to you if you can email me your questions. I can, because it is definitely shown that when patients in hematologic response are treated with renal transplant, then their overall survival as well as their renal graft survival is much superior to those who did not get renal transplant. So I would definitely say that the quality of life and everything else would be so much better for the patient. We generally do not give them deceased donor transplants just because you don't want to deplete the pool. I think the patient and the donor has to understand that that there is a risk of recurrence in the transplanted kidney. But we are doing it more and more. But even if they've achieved, and I think the only other thing is that we have kind of put it in the guidelines to really have a year of chemotherapy-free treatment or chemotherapy-free interval to make sure that the hematologic response is durable off treatment. So, if they are on daratumumab maintenance, then I would just say that, they have to demonstrate durability of hematologic response prior to renal transplant for at least a year.
Thank you. And Dr. Vaishali has put her email ID in the chat box. For those who are interested, you can take it. Dr. Bilal has another question. Since Bote is poorly tolerated, can we replace Bote with DARA, cyclophosphamide, dexamethasone, and oral Melphalan?
Right. So I know oral Velcade or ixazomib is available in India. So we did the first trial, C16007, published in JCO, which did show a quite significant response with ixazomib single agent. Tourmaline AL1 trial, which was the randomized trial for relapsed AL amyloidosis, where people were randomized to ixazomib dex versus physician choice arm. Majority of them got Revlimid dexamethasone. Again, that trial was not a positive trial because the primary endpoint was overall hematologic response that was not met, or that was equal in both arms. So ixazomib is kind of falling out of favor in AL amyloidosis. But, sure, I think, cyclophosphamide, role of cyclophosphamide, I don't really know what it is there or not. But I would probably, if you are concerned about bortezomib toxicity, I would probably just do DARA single agent and then add gradually if there is no response or if there is not, adequate hematologic, very good partial response.
And you'll never try carfilzomib because of the heart issue, right?
So, ASHU has in patients with peripheral neuropathy who cannot get Velcade. But I think in general, so we participated in a phase 1 trial of carfilzomib. Adam Cohen was the principal investigator from Penn. And, in that we had 36% of patients had grade 3, grade 4 cardiac events. So much higher than myeloma. So, I think that in the right mind, I would not really try it.
Right.
Yeah.
So throughout this, we have never discussed IMIDs. Where are they in the picture?
I know. So, the immunomodulatory agents are difficult. I know that they are the backbones of myeloma treatment. But I think immunomodulatory agents in general are difficult to tolerate in patients with AL amyloidosis, and particularly lenalidomide. So in a phase 1 trial, we showed that the maximally tolerated dose was 15 milligrams, unlike 25 milligrams for myeloma. And for pomalidomide, I think it is better tolerated than lenalidomide in AL amyloidosis. And, we do use pomalidomide on and off. Specifically patients who are not responding to dara-cybo-D and who are not transplant candidates. I would use pomalidomide in those patients. And I think that is better tolerated. So, POM I would definitely try, not REV,
Yeah. Okay. Dr. Yenifa, she's from Sri Lanka. She has a question. If you do not have access to DARA and venetoclax and your patient relapses, what's the protocol?
Right. And that's a real world issue, right? That, not a lot of countries have DARA. And I know that Dr. Agarwal keeps telling me that subQ DARA is approved in India. How many people can afford it is the question. Only Dr. Agarwal's patient population can afford it, probably. I have said this before. My sister's mother-in-law has myeloma, and she's relapsing, and now we are trying to figure out DARA, and it is expensive as hell. That it is difficult. But that again, I think that in patients like that, cybo-D with no availability of DARA, no availability for venetoclax, I would probably use pomalidomide if that is available. And I think recycling of some of the frontline therapies. If the duration of response has been 3-4 years or over a year, you could try Velcade-based regimen again to see if you can, put them back into remission. If the remission duration is less than a year, it is unlikely that, Velcade would do the trick.
Thank you. Dr. Savitri Singh has a question, whether any experience with pediatric patients?
Not really. So I will tell you that the pediatric patients do not really have AL amyloidosis. So I actually have seen a patient who's 12 years old, who was referred from Children's Hospital because they could not. And I had to go through administration because our clinic is not supporting pediatric patients, because what if the patient passes out in the waiting room? We don't have the code card to really even do it. But most of the so that person actually had localized amyloidosis of the larynx. So he presented with hoarseness of voice, and that never got better, was seen by an ENT who saw some yellowish plaques on the vocal cords and was biopsied, and that person has localized AL amyloidosis by mass spectrometry without evidence of systemic disease, without evidence of systemic plasma cell discretion, normal serum free light chains, normal immunofixation electrophoresis, and localized AL amyloidosis occurs commonly in the upper aerodigestive tract as well as tracheobronchial tree, and those do not progress to systemic amyloidosis. So those, there is a patient also in Mumbai, who actually comes to see us. She was diagnosed when she was 15. And similarly, it is just in the larynx.
And treatment of localized amyloidosis, if required, is surgery, right?
It is just surgery, or you just do scraping, because you don't want to do surgery and cause problems with fibrosis and post-surgical issues. So you just have to really gently scrape it off, and it may recur, it may not recur. But I think sometimes we have offered radiation if it is affecting or obstructing the organs of, vital organs. Then we may, because it is plasma cell derived amyloid deposition, to prevent, because the amyloid deposits are not going to melt with radiation, but the plasma cells that are producing locally amyloidogenic light chains would, be controlled by radiation. But low dose radiation, nothing like head and neck cancer radiation or anything like that.
Dr. Bhuvaneshwar has a question. Have you seen sudden death, cardiac death following bortezomib injection in amyloidosis?
Yes, absolutely. Absolutely. We don't understand the mechanism. I think it leads to, or it doesn't lead. It unmasks autonomic neuropathy, and it causes hypotension, and that the hearts are so bad that they can't handle it.
Right.
Yeah.
Dr. Rupak Kumar has a question. Is there a link between AL amyloidosis and retinopathy?
No, not really. So ATTR amyloidosis can have ocular complications, but not really retinopathy and AL amyloidosis, no. Ocular, so there is also condition of localized conjunctival or ocular amyloidosis, which is localized and not a systemic process. But this localized amyloidosis can occur. I think for Indian patient population also, I think the one thing to remember is that despite treatment of tuberculosis, despite eradication of tuberculosis, it is still prevalent, and AA amyloidosis is quite common. So nephrotic syndrome, don't just think that this is all AL. Kidney biopsy, it is crucial, and there is, if there is no evidence of plasma cell dyscrasia, most likely nephrotic syndrome is related to AA.
Thank you. Dr. Rupak Kumar has one more question. How frequent is P53 mutations in amyloidosis?
Very rare. Unlike myeloma, extremely rare, less than 5%. So it's not a proliferative disease, basically, Yeah.
Nidhi Jain wants to know management of refractory persistent diarrhea due to GI-AL amyloidosis, who has otherwise achieved complete hematological response following DARA Cyber-D. But diarrhea is continuing.
It's a very common and challenging problem that, again, in Andromeda or stem cell transplant, the organ responses occurs in 60 to 80% of patients. So it is not 100%. So persistence of proteinuria, persistence of congestive heart failure, persistence of GI involvement leading to diarrhea. It is a very, very unfortunate but a known problem. And, the supportive care, that's why plays a critical role. And, I would suggest Imodium, round the clock, Lomotil, round the clock. We also have stride octreotide depot injections, and sometimes it works, sometimes most of the times it doesn't, but it is worth a try. And then tincture of opium. So we use, it's a controlled substance over here, but tincture of opium, couple of drops, and it really, really does help. Obviously, make sure there is no a small bowel, small intestinal bacterial overgrowth, because that would really be eradicated with just some antibiotic therapy. So we do breath tests to make sure that, there is no SIBO. So things like that, any treatable causes for diarrhea. And then, all these other supportive management.
Thank you. Dr. Bilal has come back. He wants to know, he wanted to actually give melphalan together with DARA dexamethasone. He had put earlier a question. So
melphalan, it's like replacing cyclophosphamide.
Right.
And, the oral melphalan, so, Dr. Merlini's group from Italy, Giovanni Palladini, they had, before DARA and before bortezomib and before all that, they were not doing stem cell transplant, and they used a lot of melphalan dexamethasone with, some people really achieving a very durable, prolonged remissions. So, I think alkylating agents do have a role. And, I think that if people cannot afford it and people cannot really do it, then I think that, melphalan does, oral melphalan. Now, in the United States, we can't get oral melphalan. It is, it is impossible to find oral melphalan. I don't really know. I think they've stopped making it and whatnot. So that oral melphalan does have a role.
And we have easily available oral melphalan.
Right. See, I knew it.
Yes.
I know.
Okay. How is the doxycycline story? Is it out?
So I think doxycycline story is gone. I think there is, I put it on Twitter, on X, goodbye to doxycycline. So doxycycline was initially seen in our laboratory in a transgenic mouse model that it can deplete amyloid fibrils from the GI tract of the lambda 6 AL amyloid mouse model. And then, we did a phase 2 trial. We were not impressed. But then National Amyloidosis Center in London, they did a retrospective analysis of historical case control match studies, and they found that in advanced cardiac amyloidosis, doxycycline really did improve survival as an amyloid depleter, as a anti-amyloid fibril agents. A prospective trial, phase 3 randomized placebo-controlled trial from China, really showed no improvement in overall survival with doxycycline versus placebo, with obviously a standard of care plasma cell dyscrasia treatment. So I think that doxycycline is gone. And I think that the other issue with doxycycline is the photosensitivity, because you're on it forever. The photosensitivity, specifically in India or in states where there's a lot of sun, it is a lot of problem that photosensitivity and sunburn is an issue. I think I always tease Ashu, that in London there is no sun, so you can give doxycycline to everybody without photosensitivity. There was a question in the chat here about bendamustine.
Just please.
Right, and it's a great question. Dr. Suzanne Lynch and I did a clinical trial of bendamustine in a relapsed AL amyloidosis. And, we did it like at a dose which is lower than our lymphoma doses of 60 to 80 to 90 milligrams per meter square, day 1, day 2, every month. And, we did not see a huge amount of hematologic responses, but, it was difficult to tolerate because a lot of patients felt very fatigued. And the fatigue was grade 3, grade 4. They were really bedridden. And I haven't really done bendamustine off clinical trial in my real world practice, just because, I think that the 5 patients that I enrolled on the trial were really, really in a bad shape, But I think that, if you have nothing else available, I think it is a reasonable choice because it is an alkylating agent.
Fair enough. That's the last question in the chat box. Any questions from the guys here? Okay, so I think all are very happy. They got answers to their problems. You spared a lot of time. First, a beautiful lecture, and then a very long QA session. You answered everything with patience. Grateful to you. Be with us. You already given a topic to us, stem cell transplant in amyloid. Now we just need a date from you at right time.
I know. No, really, namaste to all of you. And, Dr. Agarwal, you've been amazing. So continue the good work.
Thank you. Thank you so much. Bye-bye.
Thank you. Take care, everybody. And stay healthy and well. Bye-bye. Bye-bye.